In March, we realized that modeling at that point in time was going to cause a great strain on our hospitals, outpatient clinics, ERs, that type of stuff. And so we started the COVID hotline at that time to better be able to know how to answer patients' questions, get them tested at that time, and there still are certain criteria that patients have to meet in order to get tested. And as we started seeing those numbers increase and we were doing our surge planning for the hospitals, we realized that we're going to potentially run out of beds, and so we have to come up with a way to continue to monitor these patients, potentially keep them at home, not only because of a bed need standpoint, but also trying to preserve PPE, which was in much shorter supply at that time. We had providers that were potentially going to be pulled out of the clinic, and they were going to be in the hospital. So from a limited resource standpoint, we thought that this was an excellent model to go to. When we started looking at research and data coming out of coronavirus cases, we realized that about 40% of patients are going to be asymptomatic. They're not going to need any care at all. They don't even know that they have coronavirus. There's another 40% roughly that are going to be symptomatic, but are not going to have to be in the hospital. And it's that population that, once again, this program is for. And then there's another 20% that are going to need increased medical resources, hospitalization. And so it's that 40% that is symptomatic, that doesn't need to be in the hospital, that we want to get into this program and make sure that we can once again keep them out of the ER, keep them out of our clinics, and prevent providers from getting infected, staff from getting infected, and preserve PPE. Two main types of patients are going to qualify for home monitoring. So patients that are at high risk would be the first category. So those patients may be asymptomatic, but they're over age 65. They have chronic medical conditions such as diabetes, heart disease, COPD, other things like that. So they're going to qualify. The other group is going to be patients that are symptomatic. So they're becoming more short of breath, their oxygen is low, but not to the point where we feel like they need to be in the hospital. They just need to have someone keep a close eye on them. We know with COVID-19, patients can go from feeling pretty well to end up being really sick really fast. And so we've had a number of cases where patients are doing well, and between the morning when they may do a phone call with our team to later on that evening, they become more anxious, more short of breath, and they need to be reassessed in such a short amount of time. And so we do see that from a standpoint, that anxiety, that shortness of breath, labored breathing, can really come on quick for some patients. Patients are monitored for at least 30 days. How frequently they're monitored and to what extent really depends on the particular patient. If they're asymptomatic and they are 10 to 14 days from the time of diagnosis, then we drop off to calling them maybe once a week. Other patients are different that are having a lot of symptoms, prolonged course of illness, and they're going to get more frequent calls and for a longer duration. So it's pretty patient specific. For some patients, particularly those that are at high risk and having a lot of symptoms, then what we can get them is a patient monitoring system, which is a kit of tablet, oximeter, and so that information can then be obtained through this kit. And there's a software program on it. Patients can answer questions as far as how short of breath they are, what their temperature is, how anxious are they, and then that information off of those questions is then pushed to our clinic team, and that will alert them that things are getting worse. We can actually do virtual visits through that software as well, so it's a great way for nursing staff, or if providers need to see a patient, we can actually just push a button quickly and get a video visit with that patient and actually see how they're breathing, see how they're doing, and better assess them at that point.